Welcome everybody to our RSNA panel on learnings from the exam study. We have a great group of folks here. A few words about the exam study. The exam model was a multimodal COVID-19 prognostication algorithm created at MGH. The model itself used objective inputs and outputs, designed for more generalizability of the model. The model enabled using cutoffs on the predicted risk score in order to empower clinicians in decision-making. And the algorithm itself was created with an architecture that was intended to be federated, using federated learning. And indeed, the algorithm was federated as part of the exam study to 20 plus institutes worldwide who collaborated on the model federation. Throughout that, we reached institutions around the world, amassed a total number of 16,148 cases, which is a quite sizable cohort, especially given that that was early in the pandemic. The data itself was non-harmonized and was real-world data, meaning it wasn't some sort of an orchestrated project in one institution, which involves data sharing, but actually involved putting instances of a federated learning software, Clara by NVIDIA, in 20 locations worldwide. The results themselves we found to be very impressive. The model had a significant advantage in both accuracy as well as generalizability over any local model. That transcended also the number of cases. And as you can see on the bottom right here, we actually had institutions in which the algorithm was trained on a relatively large number of cases, yet benefited a lot from the model federation exercise. And we saw that this is actually a very good enabler of collaboration. Institutions were open about signing the agreement, and IRBs, institutional review boards, were run promptly. And we actually amassed a number of collaborators, a number of data, which was kind of unparalleled. And if we kind of look at the list here, we can see a truly unique number and size of stakeholders who participated in that. Today on the panel, we hope to share some learnings from the exam study and understand better how federated learning can lead to better translation of AI innovation into the clinic. As part of that, we're going to have several questions answered by our panelists and then dedicate 5 minutes to a Q&A session. I will start off with Dr. Michal Gindi. Michal, how would you characterize the impact of COVID on cross-institutional collaborations in general?
So I think it's even beyond institutional. I think COVID made us sort of a small world in a real sense, because we quite fast understood that whatever happens anywhere really affects us. And this actually was a good promoter for people to try and collaborate. However, if you look at it from the perspective of AI and modeling, this wasn't so good. Because in fact, there's a paper that I can allude to now and send you later that actually went and tried to look at all the articles that were published throughout the last year on the topic of AI in COVID. So identifying COVID and assessing the severity and various other tasks that were tried. And you could say that most of the initial articles were really not so good in terms of how well they actually captured a good solution and how diverse the data was. And in fact, most of them were really based on a local, small sample size. And you could even argue that if more bases of collaboration were installed, people would actually be very happy to share data. But the fact that you couldn't, and the fact that everybody was waiting for some kind of a promise caused the data and the results to be not so good, even if the algorithm was reasonably okay. So I think it is actually a very good precursor to saying that we should allow ourselves to have on every place that we want a way that easily we can share data and come to smart ideas much faster. And this is the future.
I would like to add to that, if I can, that what was extraordinary, right, to do a project such as exam and having so many centers collaborating and trying to do it fast was the way we all went through what federated learning provides as an opportunity to open a backdoor in a way for sharing data. I think we've all collaborated in the past. We share data. We know how difficult it is. You have to go through processes to signatures. You have to be compliant because we are looking at delicate and sensitive information that we want to protect very carefully. This is not possible to do when you're in front of a pandemic, of a new situation where you have to come up with a rapid solution. Therefore, using again, a system and an infrastructure that allows people to collaborate from their sides in a true federated fashion was extremely important.
Maybe I could add also one thing. So, Michal, I think what really hits home here is that there were a lot of studies about COVID, and a lot of them actually, if you look at the study by itself, it had good accuracy. It was able to predict for that specific population. It had good predictions. The problem was it was not generalizable. So you take one study or one algorithm, one model, and you take it somewhere else, and it didn't work as well. And, we've seen that in some of the work that we have developed too. So the beauty of being able to collaborate in this fashion and make it easy for people to collaborate and to have these larger data sets for which are used to train the model is the generalizability that it allowed us to have, which is really key here.
I agree. I think in the past, there were lots of technique how you actually can take data from a lot of articles and try to make a sort of a new overview, but this doesn't give any in terms of managing your AI solution. This is just getting the data and getting sense of what is actually happening. And that's not good enough. Definitely not for trying to evolve an AI. So I definitely agree with what you've said.
That's a great point. I think you're referring to, doing meta-analysis on many different studies,
that's what I meant, yeah.
Which would not work like for something like developing an algorithm.
It's not a meta-analysis. You can't work with that.
I think one of the things that's terribly important is that we need to persuade patients to allow us to share the data. So if the patients allow us to use their data, it means that the red tape that's in place to protect their data would begin to disappear. Now, COVID was so special situation that it was recognized internationally that we had to move far more quickly than we'd ever done before with research. Yeah. And so certainly in the UK, there was a moratorium put on whereby we were allowed to do research with a much lighter touch of ethics and things. And so we were allowed to collaborate. We were allowed to share data. We were allowed to really fast track the research. And all the governance was really lessened. But going forward, because as Mihail says, the model that we've got now is so fantastic. The model that we had with COVID to allow us to share data internationally was so amazing that we now need to persuade patients to trust us to do it in the future with many other diseases. Because at the moment, we're going to move back very shortly in the UK. We're going to move back to our kind of much more rigid, trusted system whereby data can't leave. We need to protect patient data, and we need to shift. We need to persuade the public to trust us, to trust the scientists, to trust the doctors with their data, that we can share it much more readily. And one way to do that is using the federated approach by having, that we protect the data in our own hospitals. And so the data is held very safely, and that we can do it in this federated manner, but without having to sign all these endless legal agreements before we can actually start doing the research.
Yeah, and of course that's afforded by actually not sharing data and keeping the data under your control.
Exactly, because the promise to patients is that please let us use your data for research. We will keep it safe in our hospital. We won't give it away to other people, but we will allow algorithm development in this federated manner. Mm-hmm. And I think that's the next step that we need to move forward to.
Where you can actually ensure that the use case is the use case that's agreed upon, and there's no any derivative use of the data.
Exactly.
Yeah, and I like to say, actually, hide the data, but share the knowledge. So that's really what federated learning is all about today.
This is really a really exciting and fantastic conversation. I'll ask Marius a question. Marius, how do you think federated learning can help with data diversity? And in your domain of expertise, especially with emphasis on translating algorithms to the pediatric population and gaining better understanding of rare diseases?
Itai, I think this is a great segue question on what we just discussed, because sharing data is even more crucial when the sample is small. And in general, I think healthcare data suffers from inequitable representation in public health system and services. I will, specific to your question, I like to say that AI technology like vaccines and therapeutic approaches have been mostly focused on adults for a variety of reasons. Even before the ongoing pandemic, respiratory illnesses were the top cause of hospitalization and death in children. And as you know, with COVID-19, it was initially believed that children were less likely to be infected, but now we know that they are 16% of the total number of reported COVID-19 cases in the US. And in recent weeks, they made up about 25% of the most recent weekly reports. However, vaccines for children are emerging 1 year after being delivered to adults. And I think that AI technology is much further behind. This is a situation that is reflective, again, of a deeper inequity in the healthcare of children and of patients with rare diseases. So this is why, for me, the exam study was very refreshing. As Itai presented, the study included over 16,000 patients with COVID-19 from over 20 international hospitals, including one pediatric center, which was Children's National Hospital. So that was very exciting for me. But more importantly, to segue again on what Itai was showing, the model was able to predict the need of oxygen support for children with an area under the curve of 97%. Without using the federated data and working only with the pediatric data, the model achieved only 72% area under the curve. So I think the study, in a way, demonstrated that the transfer of knowledge from adult models to children can accurately predict outcomes for children with COVID-19. This may only be transferable when the adult and pediatric populations share clinical manifestations, such as in COVID-19. But when I think about it and beyond the study, the relevance of these findings is very high at this time when other respiratory viruses have resurfaced and children are back in school. Because pediatric hospitals are already overwhelmed and they must rapidly and safely stratify patients to the appropriate level of care. This also comes with something that I think interests all of us here in this panel, is how hospitals must be technologically equipped and computationally ready to use these type of models.
That's a fantastic segue. And I'll ask Holger about the challenges of doing exam and accessing data locally in hospitals and ensuring that data was equivalent for the needs of a project.
We heard a lot that, federated learning can help in sharing knowledge across different participating sites without having to share raw data. But also that brings new challenges, right, to AI model developers and researchers, because now they cannot see the raw data directly anymore, right? So it brings up new algorithmic challenges to make sure that your AI model still performs well across the board. So, in some cases, now that the data is not co-located anymore, you could have very heterogeneous clients, right, with different patient populations, different scanners, and that's a good thing, as we heard. It can enable us to train more robust and more generalizable AI models that can hopefully work better across a wider patient population. But as I said, it proposes challenges to the algorithms. So in a simple federated averaging algorithm, for example, might not even converge anymore if the data is too heterogeneous across the different clients. So there's a huge opportunity for research, and also this is an active field of research on how to make sure that we can have get the best model performance when dealing with heterogeneous clients in the federated learning setting. So things like smarter aggregation algorithms, regularization, domain adaptation, and meta learning will become very important.
Yeah, no, that's a really good point. And I'd say that a surprising amount of work in the Rhino Health team was actually on building workflows and data validation techniques in order to ensure that the data you need is the data that you're getting from disparate sites. So that's definitely a challenge that we deal with day by day.
Yeah, at the same time, I would also like to mention some of the privacy concerns, right? There are new challenges now regarding data privacy and security. In a study like exam, there was a pretty high level of trust between the participating sites. As you mentioned, right, there was agreements being made, and people were very willing to collaborate in using the federated learning to train a model. But down the road, we could see like FL systems might become larger. The level of trust might decrease. So how do you ensure that even the model updates that are being sent to the server are still secure and cannot be used by an attacker to reconstruct raw training data, for example, or even model poisoning attacks? So we need like techniques like differential privacy, cryptographic techniques, like homomorphic encryption to make sure that the aggregation step in the federated learning is secure.
Yeah, no, these are excellent points. I think I'd like to hand this over to Fiona to tell us about the potential of federated learning in decreasing bias during AI model development, and especially about the challenges in deploying and testing AI in resource-constrained hospitals.
So I think that's a very important point about bias in algorithms. Now, none of us think that we work in a biased way. That we kind of it doesn't we just don't think that is how we work. We don't think that in any way that we're somehow influencing what we're doing, or we kind of assume that if we read a mammogram in one place, it would be exactly the same as reading a mammogram, in America as it is in reading it in Cambridge. But in fact, unless algorithms are trained on a very broad data set, so representative cohorts from all the different places and settings in which they're going to be used, then bias is going to be introduced, and an algorithm is not going to perform as well if, for example, it was trained on a white Scottish group compared to, say, a population that is in London, where there's a lower percentage of white people. And it might be the same in the States, where there might be a much greater, or in Mexico, it might, where there's a much greater, different ethnic groups distribution compared to, say, the ethnicity of people in Glasgow, for instance. And so the opportunity to expose an algorithm to as diverse populations as possible means it's much more likely that the algorithm is going to work in every different setting that you might find all around the globe. Because what we're wanting to do is not keep having to repeatedly create algorithms. We want to create algorithms that are excellent, but are then applicable on a global scale. And the only way to do that is to ensure that the algorithm is exposed and trained to as wide populations as possible.
I love what Fiona said, because I think we're all struggling to think about what access to care and, for a project such as this, access to data represents. Because if the data collected can equitably represent populations, again, we're speaking about undercounting members of vulnerable communities. Children's is one example, rare diseases, populations that are isolated, right? And groups that don't have access to sophisticated and elite care. Then when data are not representative, then the use of data would also be inequitable. Exactly. And I think smart technologies with efficient AI solutions can improve equity in these populations. But the conundrum that I see there is access to also sophisticated technology and to computational resources, to IT resources, to research facilities, right, such as we had in doing exam. And how can we reproduce this with federated learning in the future in all corners of the world?
Exactly. And particularly in those areas whereas, as you say, the IT is much less sophisticated, there may be energy issues, where they cannot run, big GPUs and things. And so we need to think carefully about how we facilitate that internationally. So, for example, some parts in Africa are much less well served healthcare wise, but it's as important to ensure algorithms are built on that data as areas where there's much more sophisticated healthcare systems.
I think also that the chance that a clinician would actually want to purchase or to use AI is growing the more he is involved with actually working on how it's being built. So in that sense, it also helps the pickup of AI all over the world. And the more involved you are, the more you understand how it works, the more you trust it, and the more likely you are to be using it. And the better it would be. So I think in that sense, it's another reason why we should be interested in small places or places that don't have the whole 9 yards for doing it, being involved even in a small way and getting the feel of it and getting the understanding, and would push it all forward. So it is true. I totally agree.
The other thing besides sophistication technology, I think, Michal, you're using my words as well, we still have the issue of trust in AI. And I think probably COVID-19, to this explosion of solutions, fast solutions, gave in a way the perception that AI can indeed be adopted fast into clinic, can provide new insights into new diseases. But I'm not sure that conversation has been won yet. First, how do clinicians trust AI? And how does AI learn how to work with clinicians? There's still work in progress. There's still a black box somewhere in the middle. And this adds to the complexities that we've already enumerated. Very
well said, very well stated. And I'm wondering, since we are coming on time, if Mona wants to summarize and maybe give us some words of inspiration to the future of federated learning.
Thank you, Itai. I don't know if it's words of inspiration, but it's really what has been our experience and what have we learned from it. I think you all brought very good points regarding the generalizability of models and the bias and how do we tackle that. One point I want to make, though, is yes, healthcare today is biased. The way we do everything in life is biased. And to put the onus on AI to eliminate that bias, I think it's a tall ask. I think what we need to do is make sure that AI does not propagate these biases. And to the extent that it actually can counter them and can correct course, that would be very important. You can have bias in a centralized AI training. If you're getting data, as Fiona, you mentioned, from one center or two centers, the model is going to be biased to that population. So what federated learning allows us to do is increase the breadth, the diversity of the data that we're getting. It allows us to get more data from different places. It allows us, as Michal said, to have everyone be involved in this training and have more skin in the game and more trust in this AI that's being developed. So I think we're on the right track. There might also be different ways, and this is Holger, again, probably an area of research, but how do we even do federated learning in a way that not only decreases the bias because of the diversity and the number of data, but also algorithmically, can we introduce something into the actual training of the algorithm, or the way the algorithm is made to recognize bias and to correct for it? So I think, federated learning is a new way of training AI that hopefully opens up the whole arena for training different models, and without having to share data, with collaboration, but not actual physically sharing the data with each other.
So hello, everyone. On this panel, we have members of the NCI-sponsored EDRN group. And so to kick us off, the members of early pancreatic cancer detection group will show us the existing project, which is about to become a pilot project with Rhino Health to demonstrate the benefits of federated learning in doing cross-institutional collaborative data science projects. And so I'll hand this over to Eugene.
Thank you, Ty. I'm going to share my screen. So I'm going to speak for the next few minutes about challenges, opportunities for radiomics, AI, and federated learning for early detection of pancreatic ductal adenocarcinoma, PDAC. So the clinical challenge here is that most patients with pancreatic cancer are not diagnosed until symptoms develop. At that point, unfortunately, the majority of these patients have metastatic disease. They're stage 4, spread outside of the pancreas to other sites such as the liver, the peritoneum, the lungs, or elsewhere. And at that point, the treatment is palliative whenever it's stage 4. You're not going to be able to cure those patients, unfortunately. For those few who are diagnosed at an early stage, however, there is a chance for cure. Just as one example, this is a study that looked at patients who had non-invasive intraductal papillary mucinous neoplasms of the pancreas that were surgically resected versus those who had an invasive component of IPMNs. And you can see that there's a substantial difference in the surviving population. This is a retrospective study, but there are many others that support this type of finding, suggesting that if we can find this cancer at an earlier stage, there's a potential for cure. The current approach to early detection of pancreatic cancer involves a sieve model. And this is something that Suresh Chari and many others in the early detection space have espoused for quite a few years now. And generally, the idea is that you have a number of patients who are at risk of developing pancreatic cancer within the general population. And as you apply filters or sieves with known germline mutations that associate with pancreatic cancer, a family history of pancreatic cancer, having mucinous cystic neoplasms such as IPMNs within the pancreas, or symptoms such as new onset diabetes, that can help you to enrich your population to patients who are at intermediate or high risk. And then you can apply other sieves or filters to look at phenotypes of the patients, their symptoms, and also look at non-invasive abdominal imaging, such as with CTs or MRIs. And then with the highest risk population, confirm a diagnosis with more invasive procedures, such as an endoscopic ultrasound with FNA. Now, we, with the EDRN sponsored early detection imaging repository, are assessing metabolic changes in the blood or body composition by imaging to identify aggressive subtypes of pancreatic cancer that might help us to further enrich this population and identify the most aggressive actors. And we are also trying to apply more sensitive imaging methods with cinematic rendering. These are just a few examples of radiomics and artificial intelligence that we're applying to an imaging repository that the NCI has sponsored through its Early Detection Research Network program. Our group has identified radiomic subtypes called low delta and high delta pancreatic cancer. These have demonstrated different metabolic and clinical presentations in the pre-diagnostic period. These are patients who have images prior to the diagnosis of pancreatic cancer, and this is one of the foci of our imaging repository to collect these cases. The group at Dana-Farber, led by Rosenthal, Wolpin, and others, has developed automated neural network-based methods to measure the body compartments from CTs. This is a critical juncture in terms of understanding how the systemic effects of pancreatic cancer has on the body, and also to document this and index it relative to other patient populations and controls. And really exciting work from the Johns Hopkins group led by Elliot Fishman, is the cinematic rendering, where you're taking standard CT scans and then producing these 3D images to help you to enhance the subtle abnormalities in terms of textural differences and other signal abnormalities within the pancreas to really highlight small, subtle lesions and allow us to have more sensitivity in detection of these tumors at an early stage. Now, the challenge with all of those is to collect enough images to be able to render some sort of scientific conclusion and have enough power to demonstrate the value of those types of AI as well as machine learning and other radiomic approaches. To that regard, EDRN is sponsoring this pre-diagnostic PDAC imaging repository, where we're working with program officers within the Division of Cancer Prevention and have formed this imaging repository group composed of MD Anderson, Dana-Farber, Johns Hopkins, City of Hope, Stanford, University of Pittsburgh Medical Center, and Baylor College of Medicine. We have biostatistical support from Dana-Farber as well as from Fred Hutch, and imaging analysis groups at MD Anderson, Dana-Farber, and Johns Hopkins. We're excited to be teaming up with NVIDIA as well as Rhino Health for federated learning support. And we have a data lake repository that all these images are being uploaded to through JPL. So with that, we're very excited to be moving forward, and we'll be very happy to have this discussion with the rest of the group on the exciting progress that we're making with this type of imaging repository and the science that we're looking to achieve with early detection. Thank you.
Thank you for this great overview of the project. And I'm wondering, maybe we can start from talking a bit about what's the motivation to do federated learning at all with this project, and how did this come to be, Elliot?
Yeah, I think, as Eugene said, one of the challenges is data. I think everything, whether you're looking at COVID or you're looking at pancreatic cancer, is the need for data. And these days, as everyone knows who's in research, every institution has different rules and complexities, and sharing becomes the exception rather than the rule. I think all of us, the three of us, and probably everybody else involved in pancreatic research knows that if we're going to make any changes in the outcome to patients, we need large data sets to be able to look at. No institution alone will be successful, whether it's different protocols or different scanners. It's just the sheer number of patients you need to be able to come to conclusions. And looking at some of the projects Eugene mentioned, federated learning is our best hope of being able to do this now and meet all the requirements of HIPAA, and yet allowing us to do the research that's needed if we're going to change the trajectory for pancreatic cancer patients.
That's excellent. And I'll ask Michael, can you talk a bit about the challenges that you've met in trying to access broader population and more diverse data sets?
Of course, thank you. So one of the challenges that we've had in developing our metabolic models is trying to understand what is abnormal in pancreatic cancer patients, people who are going on to develop pancreatic cancer patients, and differentiating that from what's going on in the general population as we age. And so we did a study where we looked at 12,000 healthy people without cancer or heart disease at our institution, and that provided a really useful reference population that's told us a lot. But it's not a global reference population. It doesn't tell us about people from around the world. And in order to really represent what these changes mean in all of the people that we come across, we need to have a big diverse source. And that means data from other institutions. Now, most institutions are not on board with sending over 100,000 CT scans from their population. It's a big amount of data. It's a lot of privacy. And so we view federated learning as being really critical to the success of this path of trying to provide globally relevant, generalizable methods that we can use to try to find this disease early.
Hey, Michael, perhaps I could ask a question. When Eugene presented just a few seconds ago, you were talking about this imaging repository where you have all of these images. How does that play into federated learning versus like a centralized place where you have all of these images stored?
So I think that the data lake approach, where we're centralizing everything into one place, is the traditional model. This is what has been necessary in order to get these projects funded, but the administrative barriers to doing this for more than a few thousand cases are just enormous. The institutions are not excited about signing agreements that would involve shipping over large amounts of data, and certainly we wouldn't be able to do the sort of hundreds of thousands of scale studies that we want to be able to do through that pathway for a variety of reasons, but the administrative barriers are one of the largest. So I think that federation is, at least in my mind, the next generation of this, where rather than trying to centralize everything and going through the process of signing material transfer agreements and needing to manually de-identify every single case that you're going to contribute, we can keep all of the protected health information at the individual institutions and just use the federated linkage to connect the key analytic components and have no PHI linkage whatsoever. So I think that this approach is going to turn these projects into projects where we spend the first 2 to 3 years working out administrative details and the last 2 years doing science into, 4 3/4 years of science and just a little bit of administrative setup.
Awesome. So really going forward, you're hoping to get more data and more diverse data using federated learning as opposed to the traditional way you've been doing it, where you've been trying to centralize the data.
Yes.
And I think that, Michael, if I recall, even 2 years ago, you were already thinking about this idea. And I think at my time at CCDS, we tried to help you establish a kind of a federated collaboration, or maybe without a federated technology. What do you feel are going to be the main technical challenges in making this succeed today?
I think that there are a couple of layers in this. The first is that even 2 years ago, the actual technical process of setting up a federated project was pretty challenging, and you really had to understand what was going on under the hood. I think that there have been contributions now, including the NVIDIA Clara platform, that have made that more straightforward. But we do also think that the collaboration here with Rhino is going to be an important part in making this much easier for the institutions who don't have huge data science research groups to be able to come on board. We need to be able to have people participate and say, yes, I want to be on board, and have that be kind of the technical demand of them. And I think that this kind of collaboration is a huge step in that direction. It's going to make it viable. Now, we still have challenges at the individual institutions. Every institution has its own way of storing data and of making data accessible. Getting through that barrier to entry is not a trivial thing. There are other tasks involving the transformation of data into a common data model, et cetera, that need to be overcome. However, there are parallel efforts, including things like the OMOP system, which is one of the common data models that's become prevalent. There are institutions like Dana-Farber and UCSF and other institutions around the world that have proactively performed this transformation of their electronic health record data into this common format. And it means that the process of getting them into a collaborative network is basically just setting up the initial transfer link. They don't have to do all this remapping, and that's going to take months and years off of the time required to enter.
Let me just follow up what Michael said. He really said it very well. I think one of the challenges for most institutions, maybe not at Dana-Farber perhaps, but most institutions are very slim on computing resources. I mean, that's the reality. Most radiology departments, you have radiologists who are very interested in pancreatic cancer and the work and the opportunity. But then when you say, okay, we now need to share things, the complexity, the IRBs, people just kind of roll their heads and say, I just can't do it. It's just too hard. I don't have the resources. I think something that streamlines the project where, okay, if I have this software, the work from Rhino, the work from NVIDIA, where it's kind of a plug and play eventually, will really make a big difference. Because whether it's on the discovery side of new techniques for looking, whether it's some new AI formula or radiomics formula for looking at this data, it would be easy to plug someone in. I think it's the rediscovery of the wheel at every institution is what frustrates everybody. And it makes a project, as Michael said, it's a 5-year project of 1.5 years of work and 3.5 years of filling out paperwork. I think that's just unacceptable. I think, when you look at pancreatic cancer, when you speak to patients, all of us are in the clinical realm of things. When you see patients don't have the time to wait 5 years for us to get our act together. I think it's something now. And if we can discover things earlier and save lives, I think it changes, the whole process. And hopefully what we do here will also allow other people to copy this, whether in many other diseases. It's not going to be pancreas specific, obviously, but I think the pancreas working with all of us will be a good prototype of what people can do looking at the future.
The other thing that I would, emphasize that I think Michael said was so important is the establishment of standards, for federated learning. This OMAP, initiative and, other ways to standardize how the data and the ontology of the data is created, so that there's cross-compatibility or interoperability between different federated learning platforms and software systems. The onus is really on both the researchers as well as the industry to ensure that, regardless of what kind of platform we're using, and whatever, radiomics or AI, software we apply here, that there's some sort of cross-compatibility or ability to speak from one system to another. I think that's another challenge that we're going to face with the data sciences going forward, and, something that we need to keep in mind as we, build these types of systems out.
Absolutely. And besides that, Eugene, you've really done a lot of championing of a federated learning concept inside the EDRN group and with the executive committee. And I'm wondering, can you tell us a bit about how we can get researchers and organizations feel more comfortable with federated learning?
Absolutely. This is something that I've been learning over, this past year, with your help as well as, with the help of many others. David Jaffrey, our Chief Technology Officer at MD Anderson, has been espousing principles for team data science within the institution and then also in the literature. And he brings these down to 4 basic principles that will help team science move forward especially whenever it comes to things like federated learning. One of these principles is keeping observations in context. So the idea is that each measurement has an uncertainty reflected by the context surrounding the observation. So just as an example, the measurement of the body compartments, using the neural network that the Dana-Farber group has developed. What is the uncertainty there? Does that depend on the type of imaging scan, for example? Same thing with the classification of the different delta classifications that we've identified for the radiomic subtypes of pancreatic cancer. There's an inherent uncertainty whenever it comes to that classification, and we need to understand that. The second principle is the quality of the observation, in capturing that in context. And this is the idea of capturing the date, the time, the setting, and the description of the observed quantity to ensure appropriate use, and the ontology mapping, ontology being how all those descriptors relate to each other. This is essentially captured in metadata, and we need to make sure that these types of data are included with that observation that we are recording through projects such as ours. The third principle is provenance, and linking the insights to the observation. And this is the idea that the data lineage, where it came from, is encoded within that metadata and enables the ability to trust the insight. Integrate diverse observations, as what Michael was alluding to, and verify the rights of use, and when appropriate, attribute credit to the investigators who came up with those insights and also provided the data. And then finally, data governance. We want this to be foundational, integrated, and precise. The framework is iteratively matured and with integrated technical support to allow filters for data access while preserving institutional control of the data, so that patient privacy as well as any intellectual property is respected. This is, these are ideas and principles that, David Jaffrey and then our new chief data officer, Carolyn Chung, have both kind of published recently. I think this is going to be coming out in a review paper soon. So, applying these types of principles to our EDRN, pre-diagnostic imaging, I think has helped us to, formulate a set of principles that will allow us to, work together in a very collaborative manner, in a very transparent manner, and to allow us to move forward for patients. But establishing these types of ideas and making sure that we adhere to these going forward, I think is essential, so that there's trust building, that there's team, efforts, and that everybody feels like they have a fair share at the entire endeavor. And this is something that we're very excited about and very fortunate to have very good collaborators for.
Absolutely, and that's one of the reasons why we're so excited about working with your group as well, in order to ensure the ability to not compromise on the quality of science and research while doing federated learning, which is often seen as a trade-off. And in kind of taking the segue from there, I'm wondering, Mona, what are the main lessons that NVIDIA have taken from previous endeavors for federated learning? And how do you imagine big tech companies like NVIDIA collaborating with a company like Rhino in order to do the last stretch translation of a federated learning technology into the clinic?
Thank you. So perhaps actually I could talk just a little bit about what is it that we have done in federated learning today and where these learnings came from. And I think you're referring to our latest study called EXAM. EXAM was a collaboration between 20 different institutions, and it was looking at patients coming to the emergency department with COVID symptoms. And it was looking at certain lab data, EHR data, the chest X-ray, and was predicting if they're going to need oxygen, how much oxygen, and when are they going to need this oxygen. So if you can think about it, there was kind of a triage algorithm for these patients with suspected COVID infections. And what we, one thing that happened, and I guess we were fortunate, is that people wanted to help. People wanted to collaborate. It was COVID times. Everyone wanted to figure out a solution, wanted to figure out a treatment. So the threshold or the barrier to people agreeing to do federated learning perhaps was lowered. That was the initial point, after which we were able to talk to different researchers and to different institutions and explain to them what federated learning was. You have to remember this is early days for federated learning, and not everyone even knew what federated learning was. So we had to explain what federated learning is. We had to explain the security features. There was lots of conversations back and forth. And I guess one of the biggest learnings was that if people understand what you're doing, if you have transparency, it makes it easier to do the work. One of the things Eugene just mentioned is being able to give attribution back to the people who contributed to the data, and being able to know the lineage of the data is also important. So, what NVIDIA did is create the technology that allowed this federated learning communication to happen, that allowed the easy button that Eugene and I think Michael was talking about for institutions to be able to do federated learning. What we needed, and what I think Rhino is complementing, is being able to make it even easier and making the transparency more embedded in the product, so that you can take this product to fruition and take it perhaps even through regulatory channels, because now you know where the data is coming from, you know who contributed to the data, and you're able to do that in a very clear manner.
It's interesting. Some of the learnings that we've taken from EXAM is that the actual pipeline to train a model is only a small part of the solution. And I think that solution has been delivered fairly well. around data orchestration, federated data analytics, around federated workflow. There's still a lot more of white room that needs to be addressed. And going from exam study, which I think did an amazing job in popularizing federated learning and giving an early demonstration of the power of this technology, we really hope to help empower the pancreatic cancer group in order to do it this time in a much more sustainable and much more impactful way on route to clinical translation. And many of the things you mentioned, like the ability to log data and to log access and to be able to ascertain the lineage of data later, and others, I think, are going to indeed be instrumental to doing that. And we really hope that in this time we don't only run a project much more rapidly and without much of a bureaucratic hurdle, but also build something that will be a strong, repeatable foundation and have the ability to access a data set by researchers in different institutions even after the project is over, and as building a kind of a gold standard data set that can be further leveraged and do further side-by-side comparisons of algorithms, for example, which I think is another thing which would be very powerful. Folks, this has been a tremendous panel, and we truly appreciate everybody's participation. And now we'll go over to a Q&A session.